Welcome to Sex Ed with DB. I'm your host, DB. Let's get into it. What if we rethink pleasure as self-care? I recently led a study with 1,000 participants to explore how daily magic wand use impacts things like stress, relationship connectivity, sleep, and emotional well-being. The results? Pleasure is powerful medicine, and vibrators like the magic wand are legitimate tools for wellness. Want to see what we learned? Go to magicwandstudy.com to explore the findings and start your own journey to more mindful pleasure. We talk about sex ed all the time, but where do you actually shop when you're ready to explore? For me, it's all about Lion's Den. They've been breaking sex toy stigma since 1971, creating bright, welcoming stores and educational resources that help you feel good about what you like. Pleasure is personal, and Lion's Den gets that. Use code SEXEDWITHDB at lionsden.com for 15% off and follow Lions Den Adult on Instagram and TikTok for giveaways and inspo. Let's talk about lube and condoms. Here's a PSA for you. Oil-based lubes and latex condoms do not mix, but Uberlube, total game changer. It's latex compatible, silky smooth, and just 2 drops inside the condom and a pump outside can seriously boost your pleasure. Safe, effective, and sexy. Ready to level up your lube game? Use code SEXEDWITHDB for 10% off at uberlube.com. Hello, DB here, your favorite sex educator and pleasure expert, and this is DB's Pleasure Preview, where I give you a little taste of what we're diving into today, why it matters, and how it just might change the way that you think about sex. And today's episode is a really special one, not just because we're talking about aging and pleasure, but because I'm joined by someone very close to me, arguably the most close person to me. She birthed me, a beloved 15-time returning Sex Ed with DB guest, my mom, Dr. Rebecca Levy-Gant. She is an OBGYN and she has been helping people navigate sexual health, birth, menopause, and everything in between for 31 years now. Holy cow. And now she is here to talk with me and all of you about how pleasure evolves as we age. And I know that some of my mom's patients are listening. So hello there to you. So glad that you're here. And this topic just doesn't get nearly enough attention. We are told that sex dries up after a certain age, that desire just disappears, and that aging bodies aren't sexy anymore, that pleasure is something that we leave behind when we hit menopause. But research and real people tell a very different story. Some people actually even feel more sexually confident and free in their 40s, 50s, 60s, and beyond. And some discover new types of intimacy or turn to self-pleasure in ways that they never did before. But there are also very real changes that are happening in the body: physical, hormonal, relational, emotional, and those can all come with aging. And navigating all of that and understanding all of the education and information that you need to be a happy, whole person takes support, curiosity, and honesty. And that's exactly what we are here to do. Let's get into it. Hello, Mom. How's it going today?
Good. How are you, Dan?
Good. Welcome to the show we just counted the 15th time.
Are there any more things to talk about?
There sure are, because we're talking about pleasure and aging today, which is not really an episode that we have fully covered. We've covered hyposexuality disorder, and we've talked about vagina lasers in the past, and we've talked about pregnancy and COVID and mental health and all sorts of things. We talked about Notting Hill even in Rom-Com Bomb. But we haven't really had like a full episode on like sex over 50, pleasure over 50. So how do you feel about interviewing about that today?
I think that's a great idea because that is pretty much my specialty. And in the last couple of years, my practice has turned very much to Perimenopause, menopause, anybody 40 and above, I would say, and many 30-year-olds think they're in perimenopause. But,
Wow.
because I see so many people in that age group, this is a topic that comes up probably every day.
Wow. Every day. That's
Every
really
day.
wild. And I'm so excited because you are on the cusp of retiring.
I am. And
I
that
can't believe it.
that feels like I'm aging too. So perfect time to talk to me about this, although I will not be talking about my personal life. I'll be talking
Of
about my
course.
professional life.
That's to be expected. And in fact, despite the name of this segment, it's not as dirty as it seems. But we're going to get into the quick and dirty, our rapid fire segment where we get to know our expert, you, really quickly with bold questions, honest answers, and just enough spice.
Okay.
So we want to hear your rapid fire answers, and we'll get into the meat and potatoes of the conversation in a little bit. But number one, I want to know, what's the biggest myth about sex and aging?
Oh, there's so many, but probably the biggest one is that as you get older, your sex life is supposed to decline. Like out there
Mm,
in the public, like look at the fashion that they offer to older women. Look at the activities they offer to older women. It's almost like they're telling you you can't move very much, you can't do many things. So why would you be interested in pleasure? And
right.
there's very little aimed at that population. Except right now. Now there seems to be so much more talk about menopause and things that happen and things you can do and how to have a better life, but it's kind of hard to separate the fact from the fiction. So I think the biggest thing that I like to talk to my patients about is don't accept those myths about aging.
That's incredibly important to dispel. I'm glad you started with that right off the bat. Next, what is one thing that your older patients wish that they'd known sooner about sex and aging?
Oh boy, that they should have known the things that we now talk to the younger people about, that if it's not consensual and it's not pleasurable for you, please don't do it. There are
Stop.
so many older women that through their whole life have been doing it for their partner, not really
Mm,
thinking about their own pleasure. And if they had come through the way your age group and anyone younger than you has, they realize what they deserve and what they should be getting out of it, not just, oh, because my husband wants it, I wish I could or something. And that is a big thing to dispel.
that's such a good one. I'm so glad that you said that. Uh, Estrogen, villain or misunderstood hero?
Oh boy, that is so complex. I cannot give you a quick answer on that, but suffice it to say, both.
Oh, okay. We're gonna have to get into that a little later. Stay tuned.
Both of equal parts, probably. So needs big explanation to say why.
Okay, love it. Maybe we should do a separate 16th episode on estrogen.
I could talk for
Uh,
hours.
what is your favorite piece of advice to give to people who are post-menopausal?
Favorite piece of advice when it comes to sexuality or just in general?
Let's say in general. I'm curious.
In general, I think don't go gently into that good night. Like, don't go into menopause or go through menopause without good, solid information. Know what's happening to your body, know what you should expect to happen, know how to prevent the bad things from happening, know how to take care of yourself. And, especially now that I'm close to retiring, it is my extreme desire that every one of my patients who will go off and see somebody else has a plan and has a way to advocate for themselves. So that's really paramount.
That's so important. I feel like especially in this system that we have where you and I were talking about this the other day where people are just spending 15 minutes with you and that's just like not enough sometime most of the time to get through the things that you want to get through. So patient advocacy, self-advocacy is
Mhm.
so important for people to know what's going on in their bodies.
Especially women who are older, who have been
Yeah.
used to the idea that they don't deserve all these answers. They don't need to have
Mm,
long explanations. They're taking up too much of someone's time. And they really, they when they leave my office, I don't think they really feel that way anymore. They feel like they
that's true.
deserve that long period of time or, to come back and talk again if things are not completed.
Totally. And the last part of the quick and dirty, what is something that younger people totally get wrong about sex and aging?
I think I don't think it's just younger people. I think everyone is guilty of this, myself included. Like if I look at my list of patients that are going to be coming in, and sometimes I see patients that are 65, 70, or older, in my mind, I go, "Oh, that's an elderly woman." And I look in the mirror, that's me. So, so the younger you are, the more you have a look towards older people. And I'm not really sure what the number is right now. I guess people would kind of say 65 because that's Medicare age. And they kind of write them off. Like they don't think they'd be interested in hearing things about how you can make your sex life better or how you can get back to your sex life or something like that. Or what do you want to get out of your sex life? And please find somebody who can help you do that, not just accept the fact that you're now elderly and it's okay to not want, not need, not think about it. That's a big one.
So the idea is that we should be teaching women in particular from a young age that you deserve sex and pleasure throughout your lifespan,
If you
basically.
want it, right.
If you want it, which
Yes, of
most people
course.
do. Uh, okay, that was the quick and dirty. I hope that you enjoyed it. We're now getting into our interview with you because we basically want to start with the obvious here, right? Like aging freaks people out when it comes to sex. And I'm curious, like, I think that is because of media, right? Because, like you said, with old people fashion, kind of this idea that like old people in movies are kind of either portrayed as like weird and horny, or they're like basically in the grave and like they're not getting any, right? And so I'm wondering, like, in your experience seeing these patients who are like 50s, 60s, 70s, 80s, some are in their 90s, maybe 100-year-old, I imagine. What are some big like cultural fears or stereotypes that you see patients really bringing into the room with you?
Well, first, I just want to say I do have two 96-year-old patients who are
Oh my
still
god.
sexually active. And
Oh, get it, girls.
and coming to me to help with that. So I
Wow.
think it's absolutely possible. It's not something that you can just look at someone of any age and you cannot make the assumption that they are not a sexual being. Now, that being said, it's all a very personal thing. Like you can have people that are younger, 30s, 40s, 50s, let's say, and either culturally or just desire wise, they're just not that interested. That's not a big part of who they are. They don't have big desire. They're not sad to lose that part of their life as they get older. And you kind of have to weed it out. And so I think the really important thing to know is that it is the doctor's responsibility to make sure they bring up the subject. Like when, everyone has a checklist when you're going over, let's say, your annual visit or consultation. You really should ask, what is your relationship history? What kind of relationship, if any, do you have now? Do you have any problems that you might like to talk about? And as soon as I open that up, the floodgates kind of open.
Mhm.
And you can always tell whether that's something that somebody really wants to work on. And I think one of the biggest things is that women just assume that isn't it just a normal thing that once I'm paired up and I've had this relationship, whether it's, partner or, married, that over time we just kind of lose that part of it. And it doesn't have to be that way. So it's always important to ask the questions like, is losing that part of it distressing to you? Like, was there a time when it was better and you liked it? And has there been a significant decrease that now is affecting you and your relationship? If they say yes, that opens the whole gates to let's look at why, because there's a whole list of reasons why women might cease to be interested in sex or why they might have some interest, but it's just not happening anyway. And there's some very specific criteria to diagnose somebody with what we would call, lack of libido or lack of interest. And I think it's up to the doctor to kind of get that information and use that to formulate some kind of plan to help them with that whole part of their life and sexuality.
Right. And would you say in terms of like the cultural scripts, do you think I'm putting the pieces together right now that like beauty and vanity, like loss of that has anything to do with why like aging and thinking about sex and aging freaks people out because they're like, "Oh, I'm not like I don't look, my body doesn't look the same as it once did. Like, does body image and confidence like play a role in how people explain that to you?
I think a lot of times it's all mixed together. Like when, as people get older, let's say after they have kids or they gain some weight, it's a body image thing where they feel like, no wonder my husband doesn't want to have sex with me.
Mm,
I'm not attractive and I don't want to show him my body. So like I only want the lights out and I only want it to be pretty quick and I don't want to explain what I need or my pleasure. I mean, it's so has it follows the relationship pathway. So there's a couple of like little pointers. Like one is that when I'm asking these questions of patients who maybe did or maybe didn't come in specifically to talk about this, you kind of have to ask if there was a time where you had more interest. And, if someone, it's different. If someone tells you, I never have been a person that's been interested, it's never been something that has been part of my usual life, even with a partner, that's a different thing than coming in expecting that I can just prescribe a medication or even send them to counseling or something that's going to be fixed. So that's one thing. So if someone comes in and on a first visit, they say, I've never been interested, but I'd like to be, or that's one. And two is if they're not interested because they have some kind of traumatic history, like with a partner, with sex, with abuse, with violence, anything like that, that's also not something that I'm going to say, well, take this pill or use this cream and let's get your sex life back. Those issues really deserve to go to, sexual counseling, either
right.
alone with a partner, that kind of thing. And then the third thing is if someone tells me I just got into a new relationship and I'm not interested sexually, that's a problem because studies have shown that one of the things that piques people's interest in sex, no matter what age they're at, is a new relationship. Because even if you're 60, if you re-meet somebody, and this happens all the time, they went to high school with somebody and then they had like a marriage that kind of dissolved and there wasn't good sex in the marriage, then they meet somebody and that re-sparks.
Hmm.
But if they tell me, I just have a new relationship and I'm just not interested sexually, that's a little worrisome as to what's going on there.
Well,
So yeah.
yeah, I was gonna say, let's talk about what's
Mhm.
going on with our bodies as we age, because these presumably are like 50, 60, 70-year-olds who are saying maybe we're married for a while, maybe they are ending their relationships, maybe they're getting new partners. And I'm curious, like hormonally and physically, what's going on in our aging bodies above 50 that impacts our sexual pleasure? And then on the other side, what isn't going on that people think is happening?
Okay, so what is going on just in general? When people go through perimenopause, let's say in their 40s, all the way up to like 50 or 51, they're having a lot of swings of their hormones. I know we talked about this in other sessions, but basically, they're not ovulating as much as they used to be. So they're not making the same amount of progesterone as they used to be. Their ovaries are making estrogen in spurts instead of like high dose estrogen for a big part of their cycle. And they may not be cycling either. They may have irregular periods. So, with that irregularity in hormone production from the ovaries comes a lot of swings in other things. So, swings in moods, swings in depression, swings in energy levels, swings in sleep capabilities. All of those things kind of conspire to very much put sex on the back burner. And then as they keep aging and they really hit menopause around 51 or 52, and they have no periods for a 12-month period of time, which gives them a diagnosis, then all their hormone levels are low, including testosterone, which has been diving deep since 35 or 40. And that combination of no estrogen, no progesterone, no testosterone, it really wipes interest for a lot of people. Combine that with a marriage or a relationship that's been ongoing for 20 or 30 years now, and nobody's making the effort to make things spark, So low hormones, lack of interest, a partner maybe that doesn't know them anymore, a body image that's not so great. And there's a lot of people out there not having a lot of sex, but could be.
So low, let me get this straight though. Low hormones could mean basically low equals low interest. Is that kind of what you're saying?
It's part of it, yes.
Okay.
And
Okay.
and you can't really say it's a one-on-one. I can't really tell you that, "Let me test your testosterone level, and if it's low, aha, I have the reason for your low libido." It doesn't go that way. It really goes the reverse, that we know that, let's say if you test all the women across the board, some of who say my libido is very good, and some of whom say I have no libido or very little libido, they have found that the women who report better libidos have better testosterone levels. So people put that in their head to
That's
say,
the desire hormone.
exactly. So if we could just raise that in other people, then maybe that will give them back their libido. But libido is so complicated in women. And I'm not saying it's not in men, but in women much more so, that you can't just say take this and it will increase it. You have to work on the whole being, which means how's the relationship, how's your mood, how's your sleep, are you hot flashing, who wants to be sweating in the middle of the night and approached for sex?
Right.
You have to
I
really
don't.
you really have to look at the entirety of how are they feeling and address each issue, which is why I always recommend a list.
Oh, okay. What do you mean recommend a list?
Well, a list for when the doctor, or you could bring it into
Oh,
the
this is the
office, or
patient advocacy piece.
or the
Okay.
doctor is asking, what kind of symptoms are you having? If you go down the list and someone tells you I'm not sleeping, I'm having hot flashes, my mood sucks, my energy's bad, my muscle strength is bad, my joints hurt, all of these things, and the last thing on the list is, oh, and how's your libido? You're not going to get, oh, it's great. It's not.
Imagine.
Yeah, everything else sucks, but I want to have sex all the time.
Right.
It's not
Well,
happening.
so I want to know like what's really going on with our bodies as we're aging, and specifically I want to know what's going on hormonally and how that really impacts sexual pleasure.
So we'll talk about first perimenopause first. So in perimenopause, hormone levels, mainly estrogen, progesterone, and testosterone, are being produced at, I would say, wildly irregular levels. So they're
Okay.
swinging. And those swings make people feel not well. They could have hot flashes, they could still be bleeding, they could have poor sleep, they could have a lot of stress, etc. And that milieu of hormones moving all over the place makes libido down on the list, let's say. And then as you age into menopause, past the age at which you don't have a period for more than 12 months, all three of those, estrogen, progesterone, testosterone, are extremely low, if not zero. And it's a combination of all three of them that will affect the libido in menopause. Most people talk about it being a testosterone thing. And yes, some women who take testosterone feel more interest, but it's really the combination of things that are missing, because estrogen is very, very connected to blood flow. If you don't have estrogen in
Mm,
your body, poor blood flow. That's why your heart is more at risk. That's why you're more at risk for dementia. That's why, you can inflammatory blood vessels, et cetera. Also, poorer blood flow to the genital area. So if you don't have any estrogen, poor blood flow to the genital area makes less lubrication, less pleasure, less blood flow to your brain, less thinking about it, right? You have to have good neurotransmitters going on there, and estrogen is connected to those. So it's the drop in all of them that makes people not be interested, let's say, in sex after the age of menopause.
that makes a ton of sense. Mom, you've
Yes.
been an OBGYN for decades now. How is
Talk
it
about old. Thank you.
is it is it 35 years? Like how long have you been an OBGYN for?
31.
31 years. Holy guacamole. I'm curious, like, that's almost my age, by the way, which is
Thank you.
crazy. Thank you. How have your conversations about sex and aging and pleasure changed over time? Say, like, from when you were first a resident, like talking to older patients about this when you were really in the beginning of your career versus now. Like, are your patients asking different questions than they used to?
Well, being that the most recently I've had questions about things like what vibrator should I buy and things like that.
Woo!
I never used to get questions like that when I first came out and started speaking to people. Now, I've been doing hormone management and menopause management ever since pretty much I came out of my residency. So I have been speaking to women about these different things, but it has really changed that women now feel like this is something they want to fix. And in the past, it would very much be like, if I didn't bring it up, they wouldn't bring it up. And they just assumed that the decline is normal. And if they kind of regularly, maybe once a week, had sex with their husbands, that would kind of be enough. And they weren't like asking how it could be better for them. Now, with this whole kind of menopause, revolution, I think, that's going on out there. People come in going, I want that. I want the estrogen that will help my brain function better. I want the estrogen that's going to make my orgasms better, things like that. I never used to get that kind of question from patients, and now I really do. And also, the conversation that we give to our patients is different also. In the olden days, I don't go all the way back to Masters and Johnson, which is like 60s, 70s, whatever. But in those days, we used to believe that this is the only theory that we had. Like, the thought comes first, and then the introduction of sexual activity, and then pleasure, and then orgasm, and then resolution. It's like this straight line. And if you didn't follow the line, you weren't doing it right, And now we have this theory of, like, when women come into me and say, I want my libido to be better, and I ask them all the questions about, was it ever good in the first place? And is it distressing to you? All the right questions. And I say, well, it's kind of like going to the gym, like, you don't really maybe want to go there, but you go, and that metaphor. And then you do it and you go, that was pretty good. I had an orgasm. It was fun. It was intimate. Why don't we do this more often?
Mm-hmm.
That's not low libido. That's different kind of libido. That's responsive libido. And there's a big push to normalize that, for women to wrap their head around the idea that it might not be, oh, I looked at something, or I looked at my wonderful husband, I had the spontaneous thought in my head that I want to have sex with him. It's
Dr. Emily Nagoski.
Yep.
That's
and
spontaneous versus
Lori
responsive desire.
Brotto, right? A book about, sex through mindfulness. I describe this to patients all the time, and I could see in their minds how they're wrapping their head around, like, maybe I don't have poor libido. Maybe it's just a different kind of libido. And I think only if you go to somebody who has that information in their head will that conversation ensue. So that is very different, that, people feel bad about their low libido. And now when you kind of explain it, not so bad,
So they think the mindset around it maybe is shifting and changing.
Yes, which
And
is
questions
good.
about vibrators.
Yes.
which I love.
Yes, remember we were looking at like a TV show where they were trying to market, like, vibrators for older women, so that,
Oh yeah, Grace and Frankie.
The button isn't so hard to push.
They really should put. It's such a miss that they didn't actually make that vibrator.
It would be, people need it.
People need it. Okay, let's transition to vaginal dryness. You kind of mentioned it a little bit before, but because people, I think, in general are embarrassed to talk about it, but it is very common, especially as you're saying, people are aging and estrogen is decreasing. That is an increase in vaginal dryness. And I'm curious, like, your go-to advice for folks who are experiencing it, like, what kinds of products or approaches do you recommend?
Well, the gold standard, and it's funny because I am not the kind of doctor who says, I recommend you do this one thing. I always, again, the idea of the toolbox or the list, I always have a lot of different things that I offer to my patients. Like, here's what you could use. And if that idea doesn't appeal to you, you can use this. But now I have a different approach because of the latest teachings. And I also was listening to a podcast from, like, the American Urological Society a couple of weeks ago. And their bottom line at the end of the podcast was, if every single menopausal woman used vaginal estrogen, nobody would get UTIs, and almost nobody would have a problem where they were unable to have sex if they wanted to and would not be uncomfortable vaginally. So my go-to is, for every woman who will accept it and who can be on it, vaginal estrogen, because it comes in so many different ways now. Like, when I was training, we had one thing. It was a cream. There were two different kinds of cream. You could use one or the other. Sometimes your insurance would cover it, sometimes it wouldn't. But basically, that was all you had. And some people found it messy. Some people found it irritating, but you didn't have a choice. And now you have vaginal estrogen creams. You have two different kinds of vaginal suppositories that are estrogen, and they're all, quote unquote, people are always asking about this thing, bioidentical. That only means it's like a catchword for the same kind of estrogen that your ovaries would be making if they were making it. And these are basically all bioidentical vaginal estradiol. So two kinds of creams, two kinds of different suppositories, a small pill and, like, something that looks like a jelly bean. There's a ring, there's a silicone ring that people can put in the vagina that emits a small amount of estrogen for 3 months at a time, that you don't even have to take it
Like the
out or touch it,
NuvaRing.
like a NuvaRing, but it's not for contraception and it's
Right.
just estrogen.
That's
And
interesting.
there's also an insert that is made of vaginal DHEA. And DHEA is an adrenal hormone where you place this suppository in the vagina every night. It melts. And when it melts, you get a small amount of estradiol and a small amount of testosterone in the
Oh,
vagina.
wow.
And
Technology.
people love it, right? Less messy, it melts. People can decide how many times a week they feel like they need to use it, but that particular one is an every night prescription. But because all of these things exist now, and also because the latest evidence that has come out about whether or not women who we thought in the past couldn't use estrogen, like breast cancer survivors or people who have had blood clots, they can usually use small amounts of estrogen in the vagina too, even though all the breast cancer patients that come in to see me, when I mention estrogen, they go, nope, my oncologist told me never to use estrogen. And maybe it's true. You want to go somewhere else first, but if the other things are not working, it's probably fine to use a small amount of estrogen in the vagina, because it's a local problem seeking a local solution. So that's my
Wow.
go-to. That's the first thing that I would tell everyone about, that if you can and if you will, use this. There's still people who won't or don't want to or don't like any of the suggestions, or for some reason none of them are covered on their insurance or they're too expensive. Then you go to your next line treatments. And the next line treatments are things that would keep vaginal moisture, and it might keep it for a couple of days. So it's not like a lube. You're talking about something like hyaluronic acid solution. So also they come in many different forms. And I always warn people to look at the box, because you want hyaluronic acid and you want like the binder, the thing that makes it stick together. And you don't want perfumes and dyes and
Hmm.
glycerin and, alcohol. Oh, those are all irritants. So you want something that has the least amount of ingredients, and one of them being hyaluronic acid. And they come in creams, gels, suppositories, many different ways to use those. And again, goes
Is
right
that
where the
over the
money is.
counter?
Most of them are over the counter, and you can usually order them online, depends on the company that you want to use. And I do have a small list that I give out to my patients. I'm not connected to any of them. I mean, unfortunately, some of the ones that you can order online, then they have to get a subscription to it, and it might be more expensive. But I have some people that they swear by them, and that's all they need.
Is there one
So
brand off the top of your head, even though you're not backed by them, that you just really recommend?
if someone wants to use a cream, I like Via cream, VIA. That's made by a company. What's the company called? Solve Wellness, SOLV Wellness. And it comes like in a little pump bottle. My patients, even my older and elderly patients who like don't even want to touch their vaginas, they will use that, to just
And they
make
put it
things
on the
in,
outside and inside.
inside and
Inside.
outside, wherever the discomfort is.
Got it.
So yeah. So and
Okay.
then if they don't want to use something like a vaginal estrogen, and they don't want to use one of these hyaluronic things, there is a prescription for a medication that you can take orally. It's called Osphena, and that actually, if you take it every day, by the end of 12 weeks, it actually causes good vaginal moisture. So I do recommend that.
Wow.
Sometimes it's hard sometimes for people to wrap their head around, like, how can I take something orally and it has an effect in the vagina? But you know what? Everybody takes probiotics and they think it's going to give them a great vaginal result, which there's not a lot of evidence for a lot of those products. But this one actually has FDA backing, evidence-based studies behind it, and people like it.
Wow. I feel like this is a consult. How much do I owe you? Even though
I'll
I'm
let you
not an
know.
aging body yet. Um,
Everyone's an aging body, my dear.
that's true. Okay. But I want to know, let's talk about what we said in the quick and dirty, which is villain and or hero. Like why is it both? What is going on with estrogen that could make it sounds like from what you told me, it's kind of a hero. But what's
For
going on
vaginal, right.
for
Vaginal
veg?
estrogen is a very big hero. And I do
Okay.
think that if anybody even has an inkling that that might help them, they should go and have a conversation with their doctor about that. As far as estrogen being a hero or a villain in other ways, so we're talking systemic estrogen. So estrogen that you either take in a pill, put on in a patch, rub on in a cream or gel. Definite hero if you take it at the right time and for the right reasons. So people who are going through that menopausal transition where they are suffering from these wide swings in hormones, and they are waking up sweating in the middle of the night so they can't sleep, and they're having hot flashes during the day, and they have brain fog. Again, the list of questions goes on and on and on. For them, if they're a candidate, which means, again, there's another small list of questions, who cannot use systemic estrogen, like someone who's had estrogen sensitive breast cancer or someone who's had a blood clot often cannot use estrogen. Not 100% of the time, but in general, you have to ask a bunch of like what we call the rule out questions. Why would estrogen be contraindicated for some of these people? Once those questions are asked, if someone has those symptoms and they desire to have those symptoms relieved, again, top of the list for safety and efficacy would be to use some kind of estrogen, preferably through the skin if they can. So in that case, it's an absolute hero because not only does it relieve symptoms like hot flashes, night sweats, brain fog, and all that, it also gives you what we call secondary benefit. So it protects your brain, it protects your heart, it protects your bones, because the estrogen that you lose when you go into menopause puts all of those things at risk. So if you take
Wait. So there's
estrogen,
two kinds. There's vaginal
right,
estrogen, and then there's a regular cream that impacts the rest of your body.
right, that you would put not on the vagina, but you'd put it on your arm or your leg.
Okay.
Yeah, you
And do
can.
people use both at once?
They can. Very often, if I have somebody who's having all the symptoms, like hot flashes and vaginal symptoms, I will start them on a patch of estrogen with progesterone because you always have to use both together if somebody has a uterus. I will start them with that and have them come back. It's always an ongoing, check on their symptoms. Very often, if somebody's on a patch or a systemic estrogen, it will also help the vaginal symptoms. But if not, there's no reason why they can't use both.
And tell me how it's a villain.
The villain part of it is this very recent idea that's out in social media that everyone should be on estrogen. And not only should everyone at every age be on it, you should be on so much so that your doses go really high and that it will cure all. So two things. One, everyone should be on it is the villainous part. And two is that it will grow your hair back. It will make you lose weight. It will give you more energy. It will make you sleep. It will give you back all the things you're missing. It's not a be all end all. So what happens often is someone will come to my office and she's like 70 or 75 and they go, I just want a consultation. I've heard that I should be on estrogen to help me prevent dementia. That's a fallacy, So the problem is if they don't have somebody like me or another menopause person who knows what they're saying to explain it to them, a lot of them will go out there and go online and get it from some place that's not checking how old they are or checking whether they're a candidate for it, and they get it anyway. But I try very hard to explain what we call the time theory, which came from, the WHI, which is that old study that kind of made everybody go off their hormones at some point, like 20 something years ago. They definitely found that if someone is more than 10 years, or we call it out of their window, someone is more than 10 years from the time they went into menopause, it's not safe really to start them on a new systemic estrogen program, like a patch or a pill, something that goes through the skin designed to try to increase their estrogen levels in their body, because it will at that point have an opposite effect. It would make things worse. So I do try to explain, and I hate to say this to people, but you've missed that window,
And they miss it because they don't know when to ask about it.
Because at the time they were going through it, there was a big push to not have people go on hormones because a study had come out and said, look, people go on hormones, this type of hormone, and these candidates, which it might not have been the right type of hormone and it might have been the wrong candidates, and people got stroke and heart attack and breast cancer.
It's a generational thing that those people during that time heard that information and then they potentially missed
and
their
doctors
window.
Doctors also were said everyone should go off their hormones.
That's confusing. That now it's very different recommendations.
Well, because now there have been so many subsequent studies that said a lot of that was wrong information. Now we have new studies that tell us that it's very safe to use transdermal estrogen in your window of 10 years from going into menopause. But unfortunately, a lot of those women missed it because the message was different in those days.
If you've been waiting for a sign to finally try that new vibe you keep thinking about, this is it. Whether you're new to sex toys or you got a whole nightstand full of them, Lion's Den has something that can surprise and delight you, and maybe even unlock a new level of pleasure. They've been in the game for over 50 years, with 50 plus stores across the US, hundreds of trusted brands, and a knowledgeable staff that actually knows what they're talking about. And if you prefer to shop from home, their online store is stacked with options, plus discreet shipping and live customer support when you browse. From solo exploration to partner play, from curiosity to kink, Lion's Den is here to help you feel good, supported, and totally in control. Use code SEXEDWITHDB for 15% off at lionsden.com or in store. Prioritize your pleasure. You deserve it. Excitement, intimacy, confidence. Uberlube helps you feel all the things you want to feel by reducing friction and boosting pleasure. It's clean, body safe, latex compatible, and free of parabens or preservatives. Basically, it's sex lube done right. Want to try it out for yourself? Use code SEXEDWITHDB at uberlube.com for 10% off your purchase. This is so awesome. I feel like I'm learning so much about menopause and about pleasure. I'm wondering for the final two questions here, and then we'll transition into a new segment. Do you think that pleasure changes as we age, or just the way that we access it?
I think both. I think it changes because I think everyone who, let's say someone came through their 20s, 30s, 40s, and now they're aging like 50s and 60s, and they had a robust, interesting, and important sex life during all that time. If they don't have that as they're aging, I think those are the women that are going to be most distressed about it, right? Because they had something great, it was vigorous,
So
and then,
comparing.
right, they're comparing. But what happens as you age? So many things change that if you and your partner don't change with it, like the best example I could give is that at a certain age, certain positions just don't work anymore, right? Back pain, joint pain, whatever happens, it's like you got to adjust. And if you don't have the kind of relationship where you can talk about that, like that just doesn't work for me anymore, but this might, then it's going to go away if you don't talk about it and, make adjustments.
What I'm thinking about here too is that, like, you're telling me that these patients are coming to you being like, this hurts for me, but like I want to please my husband, right? Like take that example. Whereas we know from studies, like as sex educators, that 70 roughly percent of women, people with vulvas, need or desire clitoral stimulation in order to reach orgasm. So what I'm thinking is kind of like, wait a minute, it hurts for you and you're not really getting pleasure because you're really only doing penetrative sex and you just want to please your husband. Like, this is a lose-lose. Like, when
That's an educational thing. Like when
exactly.
women come to me and go, I think there's something wrong with me because I can't have an orgasm from penetration. I go, yeah, you and 80% of women, or whatever that statistic is, right? But I'm not saying, I don't say
Right.
it glibly like that, but I'm just saying you have to normalize that for them. And the biggest thing, and I know you're very much into this whole section of it, is that women have to learn for themselves what pleases them so they can teach somebody what to do. Because in all honesty, and I know you said this before, where do young men get their information from, right? Hetero
Right.
porn and their friends,
Yes.
both dumb sources, right? So, so then as they age, if you don't make those adjustments and get it into your own head as you're a woman who's getting older, like that, this is what works for me. I need to express that to my partner, my husband, whoever I'm going to have sex with. If they don't know, how can you just say sex is bad because it doesn't feel good to me if you haven't done the education of the partner, which is really key.
Yes. And it's literally just redefining sex of like, okay, hand stuff is sex, using toys is sex,
Right.
oral is sex, like all of that is sex. And the less pressure that older women in particular, because they were taught, in their generation, so many ideas about just endure it. You don't have to orgasm, just engage with it because your husband wants it. Like if they need to slowly unlearn those things. And
Yes.
honestly, like if they were just gifted a toy, I think
Right.
they would be able to see like, oh,
Right.
wow, this is something I've been missing actually in my
Right.
life.
And don't discount the part of it also that as men age, there are a lot of problems with men as far as like they get hypertension, they're overweight, they get diabetes, so they can't have an erection. So
Right.
now I'm helping this woman with her moisture, with, there's a whole other part of this that we didn't even get into, but women who have like pain syndromes where they actually need something to help stretch the caliber of the vagina, like a dilator and things like that. We do all of these things, and then their husband can't even have an erection. So you have to, it's a timing thing. I always tell them, like, timing is everything. Get a calendar, he can take his pill, you can, get yourself ready, all that. And if they're okay accepting that, if they have the kind of relationship where it's fun for them to be able to talk about that, that's great. And it will go on, and they could change it as change needs to happen. But if they've never talked about it and only have had sex one way, and now that's not working for them anymore, it's just going to go away. And both of them might be upset, but nobody's going to talk about it.
Right. So much education, so much information. And the dilators thing is so important too. I know we didn't really talk about that, but I know that from our pain episode and from my hyposexuality disorder, we have in the past talked about, different experiences and symptoms that women and people with vulvas have if their vagina needs to, like you said, stretch. Like we've talked about lube, we've talked about different ways. So if you are interested, go to Sex Ed with DB, archives and check out our hyposexuality disorder episode, because we did talk about that in that episode,
Yeah.
I believe.
It's a really important thing. And I'll tell you the truth, now that I'm retiring, I'm trying to make sure that there are other people who know how to do that. And I know there are, but I don't know if they're in my neighborhood, So I'm trying to make sure that other people know how to do that, because the women who have been coming to me for those kinds of things need to continue,
Mm-hmm. Yeah, and we do talk about that too in our vagina lasers episode. So check that out where we talk about that. Okay, Mom, we're transitioning now into bedroom brainiacs, where I'm gonna see if if this is fact or fiction. All of these statements related to pleasure and aging. Number one, menopause means the end of orgasms.
I'm going to answer that personally and say false.
Mom, please.
Okay, delete.
No, we'll keep that
Sadie.
in there. That was funny. Well, you're correct. Fiction and fear mongering. Mom, you're embarrassing me in front of all my friends.
Sorry. Would I really be your mom if I couldn't answer that question?
Okay, that's fair. Honestly, get it, girl. Like, I'm supportive.
My husband and I took your little brother out for dinner last night, and he texted me afterwards and he said, "You're such a cool mom." I was like, "Oh,
I'm not a regular mom. I'm a cool mom." That's very sweet. Okay, just a one-liner here about that. Many people report actually better orgasms post-menopause, less pregnancy anxiety.
I was just going to say,
more time, better communication. Right. So everyone is different. And even though you could experience, hormone changes and pain, some people really are happy in their post-menopausal experiences with orgasms.
If you do the work, like I said, teach your partner, teach yourself, have the time, you're not going to work, you're retired.
Right.
Get
exactly.
It done.
Okay, here's the second one, and we just talked about this. So, listener, I hope that you're paying attention. Testosterone plays a role in sexual pleasure for people of all genders.
Absolutely.
Fact. It is not just a quote unquote male hormone. Testosterone affects libido in everyone of all genders. Lower levels with age or certain medications can influence desire, but as you say, it's not the whole story.
Right. It's not the one-to-one so that you just give it back and everything will be fine. It's much more complicated than that.
Exactly. And okay, just before we go over the last one, I know there are estrogen, like replacement therapies. Is there a testosterone replacement therapy?
Yes, and I use it often, but the big problem is, like many other things in this country that are not geared towards women, there's no testosterone formula in this country that is FDA approved for women. So you have to be a little bit more inventive if you want to use testosterone for women. And one way that people use it is they prescribe a male dose, which is much too high. And then they have to use something like 1/10 of the dose. It's a little hard to meter out because some of it is in like little packets. So you have to use 1/10 of the packet, and that's really difficult. I personally use a compounding pharmacy for all of my testosterone because I know my compounding pharmacy. I really like them. And I tell them how much testosterone to put in the mix, and it comes out in a cream. And I tell people how to apply it, where to apply it. And that's the way I prescribe my testosterone. And there has been a very recent, really good study that has shown in women with mood disorders, of which one is low libido, but it's also anxiety and depression, that a certain amount of testosterone, up to and including the amount they used in the study, seems to be safe and gives women back what they're looking for in terms of better mood and better libido. So I usually aim up towards the level that's in the study.
Wow. Technology, medical technology, medicine is just like so crazy and amazing.
Well, testosterone is a controlled substance, so it is
Oh,
watched by the FDA as well. Or
is that because of doping, I was gonna say, or
Probably some of it is, but I think that did I ever tell you the story? Like when I worked in New York and I was writing so many testosterone prescriptions that the drug enforcement, the DEA, came to my office,
oh my
like
God,
one of those like breaking down the door situations with those
freeze!
vests on.
You're
Yeah,
prescribing too much
and
testosterone.
exactly, and because they just see it as a controlled substance, like you're doing it a lot. And the
Like
lady,
steroids? Is that what's in steroids?
yeah, well, it is a steroid. It's a steroid hormone.
Oh,
It's not
duh.
the same anabolic steroid that people were injecting to get bigger muscles, but it is
Right.
in that category. So the receptionist who worked at my front desk said, "Oh, you're going to take the testosterone away from Dr. Levy's patients? Oh, I would love to see that."
I'd love to see you try.
Yeah, they left.
Wow, that's crazy. I
That
did
was
not
funny.
know that.
Hmm.
Okay, the final one here before we let you go is, this is kind of a trick question, but it says
Okay.
vaginal atrophy is inevitable with aging. Fact or fiction?
Believe it or not, if you don't do something about it, it is inevitable. But we don't use that word anymore. So we
Okay.
don't use vaginal atrophy as far as like a diagnosis. And we've been trying to get it off all labeling and
Mm,
off all coding and everything. We use GSM, which is genitourinary syndrome of menopause. And that
okay.
encompasses all the things. But it is true that if people don't do something to stop it and to give the vaginal tissue better health, it's the only symptom of menopause that will continue to get worse and never better.
And all the things is that the vagina is like just not feel like, what
Right.
is the
Loses
definition?
its elasticity, gets drier, less blood flow, less congestion, harder to have an orgasm. Because we call it genitourinary syndrome, also irritable bladder, more UTIs, all the things that can happen when the vaginal tissue gets dry.
So basically, this is treatable. So there's like estrogen, lube, regular pleasure, whether that be solo or partnered, can help keep the tissue healthy.
Right. I also just do want to make one last comment, is that if someone thinks that all they have is vaginal dryness and that's why they have pain, I would urge them not to just go out and get some estrogen, have someone take a look, because it could be infection, it could be a skin condition. There's so many things that could be happening that why you're having pain, that you can't just say, oh, because everyone should use estrogen, and estrogen vaginally, I was just told, is very safe. It doesn't mean that's going to cure that condition. You really have to have someone examine.
That makes sense. I'm
Mm.
sad that we're at the end here, but I really appreciate you being on. Honestly, there are probably episodes that we didn't even find that you have been on before, but we know this is at least your 15th time here.
Sneaky.
And thank you for being you, for being on this podcast so many times. Where can people find you?
Well, I'm in a bit of a transition right now,
Yeah.
so they can definitely find me. If they're interested in reading my book on perimenopause, they just have to go to Amazon or to Wiley Publishing and look for Perimenopause for Dummies. Of course, they can look at the website of my practice, which the first thing that comes up is this person's retiring soon. So it's not going to be there very much longer, but I will be doing something after that. And I would love it to come back on once I start my new venture.
Yeah.
But the website of the current practice is premierobgynnapa.com.
Love it. I love you so much. I'm so grateful
Thank
to
you.
have you as a mom, as a mentor, as someone who I've really, like, in many ways, based my career off of, like, the kind of education and information that you give. Like, I'm so proud to hopefully in some way follow in your footsteps in that way.
Mhm.
So,
You are.
oh,
And I'm
uh,
following some of yours as well.
oh, cute.
Yeah.
Okay. All right, beautiful listeners, stick around for the afterglow in a second, where we will wind some things down. We'll reflect on some big takeaways. We'll leave you with one juicy thing to try, think about, or explore before next week. See you in a sec. Welcome to the Afterglow. That was the amazing Dr. Rebecca Levy-Gant, or as I call her, Mom. I'm so proud of you, Mom. I know you're listening, and I can't believe that you are retiring this week. Oh my God, congratulations. If you, gorgeous listener, want to say congrats to my mom on her retirement, comment on this episode on Spotify, leave a review on Apple Podcasts, and I'll send them to her as part of a little retirement gift. I know she'd love to hear from all of you and how much she has impacted you just from being on this podcast the last 15 plus times. Don't worry, we'll still have her on every season. She will still have the wealth of knowledge that she has despite her retiring. And yeah, I just really loved this episode. I don't know about you, but I feel like as a 32-year-old who's already noticing differences in my body and my mind when comparing to my 22-year-old self, I'm feeling really hopeful after that conversation about sex and aging. We just don't hear enough honest talk on this subject. And when we do, it's often laced with shame or silence or like, the punchline that like an older person is having sex or they're too horny or they're in pain, whatever it is just like not typical of people who are in menopause. But my mom really reminds us that your sex life doesn't just disappear with age. In fact, that's when it can really thrive for a lot of people. In this episode, we talked a lot about how menopause shifts things for people, desire, sensation, comfort, but that doesn't mean that pleasure is off the table. Vaginal estrogen was so interesting to talk about, how it could be a game changer for people, but it won't be like a catch-all. It won't like be a silver bullet that solves everything, but it can improve a lot of things from arousal to comfort. And so many people don't even know that it's an option. And what really stuck with me the most is what she said about her patients, that more and more women in particular are coming in and saying, I want to feel better. I want to feel more. Seeking that from your healthcare provider in and of itself is powerful. It gives you agency. So here is your pleasure practice of the week. If there's a vaginal thing going on with you, no matter your age, if there's dryness, pain, discomfort, whatever, anything that you've been experiencing that you've been nervous to bring up with your doctor, aging related or not, write to them. Send that portal message. Like after this episode, after you hit pause on your app of choice, go ask the question. You really deserve the answers, the options, the support at every single age. Thank you so much for listening. I love y'all. I love you, Mom. Thank you for being on, and I will talk to y'all next week. Bye-bye.